Right, so let's get started then. It's our last Dementia Open Forum for this year. It's my great pleasure to have Tim Rittman from Cambridge here. And Tim is a consultant, dementia consultant at Addenbrooke's Hospital, and also has an appointment at the university. And he's doing a lot of work in diagnosis for MCI, Alzheimer's disease, and also the less common forms of dementias. But today he will talk more about early diagnostics of dementia. Just as again housekeeping, if you could, we switched off all your microphones, and keep your microphone and maybe video off. If you have any questions, feel free to type them in the chat. We'll have a Q&A session at the end, and then if you want to come on, then please switch on your microphone and your video, and you can ask your question in person, or otherwise just type it in the chat, and I will read it out for everyone. But now I hand over to Tim. So Tim, if you could share your slides, and the floor is yours. Thank you for joining us.
Great, thanks, Michael. Thanks very much for the introduction. I know Norwich very well, having done a lot of my training at the Norfolk and Norwich Hospital. So it's a great pleasure to sort of come back and be able to do this talk. So what I'm going to talk a bit about today is sort of early detection of dementia. So how early can we know that people have got some kind of neurodegenerative disease, and how can we possibly look at trying to pick that up? So I'm a consultant neurologist at Addenbrooke's in the memory clinic here, and I run the clinic for some rare types of neurodegenerative disease called progressive supranuclear palsy and cortical basal degeneration, and I run the dementia genetics clinic. So it's 2 days a week doing clinical work, and then 3 days doing academic work. I think I'm going to talk a little bit about some of my work today, and that of my lab group. So firstly, let's start off thinking about what dementia is and how far we've come in the understanding what's going on in the brain. And I think that helps us to then sort of get to where we are in terms of trying to pick up these changes earlier. So the first description really, or the first mention of dementia, goes right back to AD 150 of this sort of senile dementia, which is sort of recognized to be sort of age-related memory problem and cognitive problem. It wasn't really until the sort of late 1800s, early 1900s, when a bunch of neuropathologists, so people who look at the brain under a microscope, so Arnold Pick, who describes what we now call Pick's disease or frontotemporal dementia, and his mate Alzheimer, and they had a friend called Dr. Levy as well, who described Lewy body dementia, and they were working in Germany around Munich, looking at the brains of people with some cognitive and memory problems, and describing what they saw. And so Alzheimer describes this woman called Augustus D, who was in her early 50s and had memory and other problems. And for a long time, people thought that because this patient was young, that Alzheimer's disease was a disease of young people, and that actually senile dementia was something completely different. And it wasn't really until the 1970s when people started doing more neuropathology studies on a range of different people, and we started to get brain scans. So on the right hand side is one of the first sort of brain scans of someone with dementia or Alzheimer's disease. We started to see that those changes that we'd seen in Alzheimer's disease in those young people were actually the same as the changes that we'd seen in older people. So it's a relatively recent concept that actually Alzheimer's disease is a late onset dementia. And of course, for most of history, the commonest cause of dementia has actually been syphilis, rather than any of these neurodegenerative diseases we think of today. And when we talk about dementia, it's really an umbrella term for lots of different things. So here I've tried to sort of point roughly to which bit of the brain these different diseases affect. So there's some diseases that affect mainly the back of the brain, so dementia with Lewy body is Alzheimer's disease, and this subtype of Alzheimer's disease called posterior cortical atrophy. And there's some bits which affect the front of the brain, so vascular dementia, frontotemporal dementia. There's some which affect the language parts of the brain at the side here, there's primary progressive aphasia. And there's some other neurodegenerative diseases that cause sort of memory and movement problems like progressive supranuclear palsy, which affect this sort of bottom of the brain called the midbrain and brainstem and basal ganglia. So So when we talk about dementia, we're talking about lots of different types of diseases and syndromes affecting specific parts of the brain. And what we've learned over the years, really from sort of 1980s onwards, is when you look at the brains, you see little clumps in brain cells, and those little clumps in the brain cells are made up of different types of protein. So two of the main ones that we talk about are beta amyloid and tau, and you find both beta amyloid and tau building up together in Alzheimer's disease. And there's some other diseases like frontotemporal dementia where you mainly find tau. And we're still continuing to learn about these proteins, how they clump together, what other things might be going on in the brain. So there might be inflammation, there might be cell loss, there might be loss of the synapses, those connections between brain cells, and all of those link together to lead to these different types of dementia. So at the bottom here, I've got these sort of proteins, so beta amyloid, neuronal tau, and another one called TDP43, and those build up in brain cells and sort of link roughly, not one-to-one, onto these different diagnoses. And when people talk about dementia, they normally talk about these syndromes, these different diagnoses. And those diagnoses like Alzheimer's disease, frontotemporal dementia, this is a motor neuron disease, and they are made up of different clinical features, so changes in memory and thinking, and changes in movement. And so why talk about this in terms of early detection? Well, increasingly we're talking about trying to treat the different neuropathologies, the problems that are going on in the brain. And those treatments are mainly focused on these proteins down here. So to really understand and pick up people for these treatments, we need to be able to link these syndromes to these different proteins, which is not straightforward. So we're moving into a phase where actually these treatment trials are starting to happen. So at the moment, we don't have a treatment which we can confidently say stops or slows down the disease, but there are lots of trials that are going on. So these three treatments here are all targeting Alzheimer's disease, and I mentioned this beta amyloid protein, and all these treatments target this beta amyloid and to stop it clogging up and building up in brain cells. So solanezumab was the first a few years ago, which some early signs but didn't work in a larger trial. There's a drug called aducanumab which failed in some clinical trials, but there's various views on whether it works or not. They did a bit of sort of fancy stats and said, well, maybe it works in some people, and on the basis of that, it's been approved for use in the US. It's I think if it does work, the effect size is very, very small. So it's not that you would notice any improvement in your memory, for example. And it comes with about a third of people who get this drug have either brain inflammation or brain hemorrhage, so bleeding in the brain. So it's quite a hard sell, to be honest. To take a drug that's quite intensive, won't make you noticeably better, and gives you about a 1 in 3 chance of having brain inflammation. Recently, there's been a press release about a drug called lecanemab, and that has we haven't seen all the data on that yet, but hopefully in the next couple of weeks we'll find out a bit more. Again, it's not very clear yet whether this actually works, and it comes with about 1 in 4, 1 in 5 chance of brain inflammation and brain hemorrhage. So I mean, at least these trials are happening, and things are moving forward. And we're not only just targeting beta amyloid. There's drugs which target tau. So I mentioned a disease earlier called progressive supranuclear palsy, or PSP, where tau builds up in the brain, and we were involved in one of the trials of a tau treatment called gosuranemab, which unfortunately didn't work. But I just highlight that these trials are starting to happen. And if you look at parallels with cancer, for example, it takes hundreds and sometimes even thousands of testing different drugs before we find one that works. So we're still in the early days, really. And there are other approaches as well, trying to look at neuroprotection, so protecting brain cells from dying, and fancy things like injecting fancy things called oligonucleotides into spinal fluid, which might work for some genetic diseases like Huntington's disease. So I wanted to sort of preface everything really by saying that one of the criticisms of these trials is that they're catching people too late. So it may be that once you've got symptoms, it's too late for treatment. The challenge with that is we don't actually know how early people develop the disease, or the changes start to happen in the brain. What we do know is that there are a number of things which you can do, which in terms of lifestyle, which might make some of these diseases more likely later on. And the Lancet, there's a group called the Lancet Commission who have looked at all these different lifestyle risk factors. So education in early life, is hearing loss, head injury, and so on in midlife, and then smoking, depression, social isolation, diabetes, and so on in later life. And if you have any of these, it makes you a bit more likely to develop a dementia. So again, if we can pick people up very early in the disease, we might be able to either give people a treatment to slow down or stop the disease, or we might be able to address some of these risk factors and reduce people's chance of going on to develop full-blown Alzheimer's disease or frontotemporal dementia or vascular dementia and so on. But so the challenge at the moment is we don't really know when things start. So when is early on? How early do we need to treat and catch people? Well, up until recently, the best evidence we've had has come from genetic types of dementia. So genetic dementia is rare. Most people don't carry a faulty gene with their Alzheimer's disease or frontotemporal dementia and so on. But there are some people that do. And this comes from a study run by a guy called John Rohrer down at UCL. And we've contributed to this of people with genetic frontotemporal dementia. So this type of dementia causes changes in behavior and sometimes changes in speech and language. And if we know people carry a gene, we can study them, and we can study their relatives as well. And their relatives may or may not carry the gene, which means that at some point they may or may not get this type of dementia. And we can follow those people up over time and look back, sort of using a time machine really, to go back to people before they developed symptoms. So there's a number of people who carry the gene, they'll get the disease at some point, and we can look back, say, in time to see when they first started having changes on their brain scan. And we can pick those changes up about 10 years before people develop symptoms. Now, the question has always been unclear whether this early detection in genetic types of dementia translates across to sort of common or garden non-genetic type of dementia. So we've sort of tried to address this with a study that we published recently using the UK Biobank. So some of you might have signed up to the UK Biobank. I know my mother-in-law is certainly one of the volunteers in this. There's about 500,000 people across the country, and they get invited to come along to a test centre. They have a whole load of questionnaires. They have some tests about their memory and thinking. They have questionnaires about their lifestyle, their smoking, weight, and things like that. And a proportion of people have brain scans as well. I'll come back to the brain scans a bit later. But what we did is look across these 500,000 people. And they're in the age range where some of them might go on to develop different types of dementia. And indeed they did. So here I put the numbers of people who during their follow-up in the UK Biobank have gone on to get different diseases. So we've got almost 3,000 with Alzheimer's disease, just under 2.5 with Parkinson's disease, and a smattering of other different neurodegenerative diseases. And what we did is look at the memory and thinking tests and their sort of general function tests back at baseline when they were first recruited, so years before they got a diagnosis. And in most cases, this was between 5 and 9 years before people received a diagnosis. So could we pick up any changes on these tests at that point? The first thing we looked at was fluid intelligence. So I'm not going to force you to answer this, because I know if I tried to do this while I'm on the spot now, I would get the answer wrong. But there's 13 different questions of this sort of kind, where it's a sort of logic test, and this is testing your sort of speed and flexibility of thought, something called, and this is called fluid intelligence. And when we looked at those results from that, I'll show you these here. So basically, if you're normal, you're in this shaded bit here. So anything within that shaded bit is normal. So if you look at Parkinson's disease, which is PD here, the people with Parkinson's disease have no change in their fluid intelligence. For the more statistically minded people, this is a type of Bayesian analysis, and this is called a region of practical equivalence. So if you're outside of this shaded region, this region of practical equivalence, there's a difference in your fluid intelligence. So if we look at Alzheimer's disease, very clear that people with Alzheimer's disease here, the AD group, were way down on their fluid intelligence scores, and the same with some of these other types of dementia and neurodegenerative disease. So frontotemporal dementia, progressive supranuclear palsy, dementia with Lewy bodies, all had worse fluid intelligence 5 to 9 years before they got a diagnosis. We looked at another test of memory. So this is a relatively simple test. So you're flashed up a screen like that, and then the screen's covered up, and you simply have to say where the pairs were. So the pairs matching task. So this is a task of working memory. You have to hold those positions in your working memory for a few seconds. And as you might expect, people with Alzheimer's disease, who often have memory as their first symptom, did worse on this test. They made more errors than other people. Again, if you compare that with people with Parkinson's disease, they made no errors on this test at all. And there were some other memory and thinking tests which were sort of specific to these different types of neurodegenerative disease. And there were other types of memory tests, for example, that the people with Alzheimer's disease did worse on. So here we can say, well, not only can we see changes on brain scans for 10 years before symptoms in genetic types of dementia, actually, even in non-genetic types of dementia, we're picking up subtle changes in memory and thinking in these different types of dementia. Interestingly, these people rated their overall health as much worse than the general population as well. So Alzheimer's disease, frontotemporal dementia, Parkinson's disease, progressive supranuclear palsy, all of the people who went on to get these disease, so that their overall health rating was lower than people who didn't go on to get these different types of dementia. So if we can address pick up some of these people early, we might be able to not only prevent them getting dementia, but also improve their quality of life. And then just one more sort of these sorts of graphs, and looking at falls. So people with Alzheimer's disease tended to fall more, but I mentioned earlier, I run a clinic for these people with progressive supranuclear palsy, or PSP. It's a rare type of neurodegenerative disease, but it causes particular problems with balance. And these people were falling 2.5 times more than they should be for their peers were at the same age. So we're seeing very sort of specific changes for these specific different types of neurodegenerative disease years before people get a diagnosis. And that potentially gives us the opportunity to develop a screening tool where we can pick people up and put them into clinical trials for the disease-modifying treatments I mentioned earlier, to try and stop or slow down the disease, and to put people into trials of prevention to see if addressing some of those risk factors might help stop or slow down the disease. So we've picked up changes early in memory, thinking, general function, and can we potentially change people's risk? So I've talked there about the sort of picking up people's change in memory and thinking. Can we actually use brain scans to do the same sort of thing? And here on the left is a normal looking brain, and on the right is a brain scan of someone with Alzheimer's disease. This is quite a dramatic change. You can see that these ventricles in the brain, which should be there, but they're just much, much bigger than they are normally. And you can see around the memory bits of the brain at the sides here, there's a lot more space there than there should be. So there's general brain, there's some brain shrinkage. So can we use information from brain scans to add to what we normally do in clinic? So normally when we make a diagnosis, we see people, we take a history, so we go through what's been going on and their symptoms, we examine them, and we do some cognitive tests, and that's the basis for the diagnosis. We then look at the brain scan to see if there are some of these changes we might recognize, and to exclude other things like strokes and brain tumors and so on. But at the moment, it's more of a sort of squint at the scan and say, well, it looks a bit like Alzheimer's disease, or looks a bit like frontotemporal dementia. So can we do a little bit better than that with things like artificial intelligence? So it's set up a study a couple of years ago to try and look at using some of these artificial intelligence and machine learning methods that are in the research world and translating them across into the memory clinic. So this got picked up by the papers. So I had a couple of crazy days of being interviewed by various people, and a lot of colleagues said, "Oh, I read about you in the Guardian," or we read a bit about you in the Times. None of my colleagues noticed that we've been front page of the Express newspaper. This was just at the point where we're setting up the study. Now I can hopefully show you a couple of the things that we've done using this AI in early detection of disease. So if you don't know much about artificial intelligence, there are different types of artificial intelligence, and one of the more sort of widely used these days is something called a neural network. And I've put this sort of fancy complicated diagram, which is a bit like a factory, to be honest. If you look at the left-hand side, there's some green boxes, and you plug in some numbers, so 1 to 55 different sort of pieces of information. And in this case, our pieces of information are bits of the brain and how big they are or how small they are, and how thick they are. So volume and thickness of different bits of the brain, and that gets crunched by these little blue boxes in the middle here. There's 128 little blue boxes which do each does a fairly simple sum, and then passes that information on to another set of little blue boxes which do some more number crunching. And the final output of all that number crunching is this little yellow box, and that yellow box tells you a number between 0 and 1 of your chance of having Alzheimer's disease. So 0 will be no chance of Alzheimer's disease, 1 would be absolutely, yep, this person looks like they've got Alzheimer's disease, and 0.5 will be not sure, could be either way. We just had this paper accepted for publication. If you want to read more detail, it will be out soon. So how did it work when we use this this neural network? Well, firstly, we trained the neural network to identify Alzheimer's disease in a sort of research group or research cohort of people who we know we're confident have Alzheimer's disease, and it did very well. It got sort of 80–90% accurate. And then we tested that again in a separate group of people just to make sure it still worked when we took it to another group of people, and it still worked in another data set of people with Alzheimer's disease and other types of dementia. So then what we were interested in doing is taking it to the biobank, the UK biobank, which we've talked about before. So within those 500,000 people in the UK biobank, 40,000 of them have had brain scans. And when we looked at those sort of 40,000 people, about 1,300 of them had brain scans that, according to our neural network, our artificial intelligence algorithm, looked like Alzheimer's disease. And the interesting thing about these people so just to reiterate, these people are healthy, and we excluded people if they'd already got a diagnosis of Alzheimer's disease. So these are people without any kind of diagnosis, sort of healthy people from the population. And interestingly, when we looked at those people, they had, as you might recognize this, they had worse fluid intelligence, they had worse overall health. they had worse memory. So they looked very much like those people that we picked out earlier who went on to progress to have Alzheimer's disease later on. Now, I don't know at the moment, because this is early days. I don't know whether these 1,300 people will definitely go on to get Alzheimer's disease or another type of dementia. But at the moment, we can say that they've got the same profile as the people who went on to get Alzheimer's disease in the UK Biobank more generally. Crucially, though, not only do these people have that sort of memory and thinking profile, they had risk factors that we might be able to change and address. So they had higher blood pressure. They'd smoked for more years. So we've been able to use this artificial intelligence algorithm to pick out a group of people who are at high risk of developing Alzheimer's disease, and with risk factors that we can potentially address to stop or slow down their disease in the future. I think this is mainly sort of proof of concept. I think there are improvements we can do to our algorithm. There's more information that we can feed into the model from, say, other things like cognitive information or other types of brain scans. But we can at least use the same kind of approach to identify people at high risk and suggest that they might be appropriate for trials and for prevention studies. Now, that's about sort of people who might develop dementia in the future. What can we do about people now who are coming to memory clinics and try and improve that diagnosis and at this point? So I'm going to sort of take you through this algorithm that's been developed by one of my colleagues in Cambridge called Zoe Kurtzy, she's developed this algorithm called a digital neurodegeneration detection algorithm. I'll show you how we sort of use that and what it does. So the challenge here is that among the different types of dementia, there are different chances of surviving. So if you have semantic dementia, from the time of diagnosis, you might survive on average of sort of 8 years, give or take 2 or 3 years. If you have progressive supranuclear palsy, your prognosis is much worse, sort of 2.5 to 3 years at best. A little bit longer if you do particularly well. But even within, say, frontotemporal dementia, within Alzheimer's disease, you might survive 3 years, you might survive 9 years or 10 years. And at the moment, we don't have a good way of picking out those different people and how fast or slow they're going to progress. So this was a challenge that Zoe and her team tried to address with this machine learning algorithm. We particularly focused on the earliest type of memory problems called mild cognitive impairment. So this can be a precursor to Alzheimer's disease. There can be other reasons why people's memory is not as good as it should be. And we'd like to be able to pick out those people whose memory is going to stay stable versus those people who are going to progress to Alzheimer's disease, and particularly to pick up those people who are going to progress much more rapidly and need additional intervention sooner. So the algorithm is sort of split into 2 bits. Firstly, it categorizes people and recognize whether they've got dementia or not. And then once it's done that, it gives you a score, which gives you an idea of how fast or slow someone will change in the future. And when we've looked at this very early stage of mild cognitive impairment, trying to predict those who will go on to get Alzheimer's disease over the next couple of years, this has proven to be very accurate. What we've also done is looked at a study of people with the Berkeley Aging Cohort study. This is back study at the bottom, and that includes people who have got no cognitive problems at all, but they were followed up in the community and they went on to get Alzheimer's disease. And this machine learning model was able to pick out those people and how quickly they were going to change and progress to Alzheimer's disease. So it sort of works in that sort of research environment. What we don't know, or what we haven't been able to test up until now is whether it works in the real world, in the sort of messy, noisy world of NHS memory clinics. So I've set up a study called the Quantitative MRI in NHS Memory Clinic study, and we're hoping to set this up in Norwich in the near future. But we're now recruiting from 9 different memory clinics across the country. We started in the middle of COVID, which wasn't a great plan, but you know, these things happen. But we've now recruited about 400 people from across the country who have had brain scans, have had cognitive tests, and these are not the highly selected group of people who come into research studies. These are the sort of all and sundry people who walk off the street into NHS memory clinics. So we can then use that group of people to say, okay, we've got this machine learning algorithm, looks like it works really well in our research study. How does it perform in the real world? So just to give you some preliminary data from this, we're still working through all of the validation, but it's looking good so far. And this gives you an idea of how we might use this data. So we've got people with no dementia, and they have very low scores here. So these people are going to stay stable over time. People with mild cognitive impairment. Now, some of those people are going to stay stable. Some of those people are going to progress over the next 12 months. And then people with Alzheimer's disease. And even within Alzheimer's disease, there's a big range of how fast or slow people change over time. But what we can do here, we can say, well, these people we can be relatively reassuring to in the green box. And the sort of amber bit in the middle, well, these people we need to follow up and support as best we can. And then we can identify these people in the red box here who are going to progress much more quickly and need additional intervention. So we can then put in measures, for example, to prevent people being admitted to hospital as often, or being admitted to nursing homes when they don't want to be, and helping to support them and their family with additional intervention. So, so the idea with these algorithms is that we implement them in the real world, and we're working now with a software company to try and implement this into the NHS, so that when you come to the memory clinic, yes, you still have your history and examination and your cognitive test. That will all stay exactly the same, and that sort of patient-doctor interaction remains completely unchanged. But what we can do now is get as much information as we can out of these memory and thinking tests, out of these brain scans, so that we can give that information to the doctor or nurse who's making the decisions. And depending on the score that people have, we can then give a sort of a guide of suggested management. This person's progressing quickly, this person's progressing slowly. These are different things you might want to think about in that scenario. And it may help us to make diagnosis quicker. At the moment, if we're unsure about a diagnosis, we might send people off for PET scans, which are very expensive, or for lumbar punctures, which can be quite invasive and uncomfortable. Whereas if we can get more information out of the brain scans using these artificial intelligence type algorithms, we may be more confident earlier and not have to send people for these additional tests as much. I'm just going to mention very briefly that we're also trying to set up blood testing across the east of England as well. So these are literally hot off the press results, and Michael very kindly donated has been involved in this study and sent some of the blood tests across to one of our colleagues, Ed Needham, over at the hospital, and he's got a fancy machine which can look at some of the proteins that we mentioned earlier as being involved in these diseases. So this is a type of tau protein here, and you can see that they've got people with no dementia in this red box here. Sorry. And some people with Alzheimer's disease have a higher score in this blood test here. Now, this is literally the first set of blood tests that we've run through this. So this is really early days, and this is really just making sure that the machine works and that we can get some results out. So we're hoping that we can bring this blood test to the clinic over the next sort of 6 to 12 months. Again, just to add information to that decision making, so we can be more confident about the diagnosis earlier, and help to pick out those people who have specific types of dementia, in particular Alzheimer's disease. So early detection of dementia. So I hope I've been able to show you that we now have a better understanding of when the dementia starts and when we can pick up some of the earliest symptoms. And that gives us a potential window of opportunity if we can identify these people who are high risk for going on to get Alzheimer's disease or another type of dementia. So we can offer them early treatment trials and prevention strategies. We're able to do that potentially by screening people with early tools that pick up those early memory and thinking changes. And if we then add to that artificial intelligence, particularly applied to neuroimaging, that might help to screen these people even further and identify these people at particular high risk of disease in the future. And I've shown that there's exciting things. It is a developing area, and blood tests are coming to hopefully to a clinic near you very soon. So I certainly haven't done all of this work on my own, and this is a few of my lab group. I need to update this because of the picture, because of the few people joined recently, but some that I've highlighted in bold, the people who have contributed to various bits and pieces of this research here. So David Whiteside's been involved in the blood tests. Marcella Montanesi has been involved in this study of recruiting people from memory clinics, and Noel did the work on detecting cognition and function very early in disease, and a whole host of collaborators, including Michael, working on this. So thanks very much for your attention. I'm happy to take any questions.
Brilliant. Thank you very much for this overview, Tim. If you have any questions, please type them in the chat, or if you want to switch on your video and ask them in person, you can do that as well. And Louis is early out of the blocks here, so he's already having a question. Very interesting. Thanks, Tim. You mentioned early working memory impairment in future Alzheimer's disease patients from the biobank data, but did not mention episodic memory. Is it the case that it was less predictive with the episodic memory test used in biobank?
No, I mean, it's actually quite hard to measure episodic memory, and there is an episodic memory test in the biobank, and people with Alzheimer's disease did do worse on that test as well. I just didn't show all the results that we found. There was another test of numerical memory as well, where people with Alzheimer's disease did worse. So yeah, I was being a bit selective in what I was showing, rather than that people didn't do worse on those tests. Yeah. Brilliant.
Yeah, maybe I can follow up on this. Did you, I can't remember, I've read the paper, but I can't remember, so I'll ask you this forum. But did you look as well at depressive symptoms in these people in the biobank, if they had any depressive, because that can affect, of course, a lot of the cognition and can lead to potential diagnosis of MCI? Yeah, we did. I mean, when you're looking at the biobank, it's always slightly tricky to look at things as confidently as you'd like to. So the measure of depression was, have you seen your GP for depression? Have you seen a psychiatrist for depression? And actually there was no difference on those measures, which I was a bit surprised at. And actually looking at some of the other things which that Lancet Commission has picked up, things like hearing and sleep and alcohol, actually didn't differ between in the people who went on to get dementia. So maybe though, I think there's an argument that people in the biobank are not like the rest of us. They're a bit like my mother-in-law, well off, middle class, willing to go and do all the tests, and more healthy than the rest of the population. So that might explain why some of these things we didn't find. Yeah. There wasn't actually any link with depression that we found. Interesting. Yeah, I would have expected that as well, but yeah, interesting. And Nada has a question. Thanks, Tim. Very interesting work. In regards to the real-world application of the algorithm for predicting patients' progression, were you able to look at which specific factors were behind the fast progression? Mm-hmm. Any insight on areas to be targeted? Yeah, that's a very good question. We haven't got that far at the moment. We know which brain regions are
associated with faster progression, and they're all the ones that you might expect and usually would sort of pop up in brain imaging studies of Alzheimer's disease. So bits of the temporal lobe, bits of the parietal lobe. But sort of going a step further and saying, what other factors, so there might be lifestyle factors or factors of sort of comorbid disease and so on, would contribute to that. I think that's a really important next step. We haven't quite got to that point yet, but yeah, we should do. So it's a good suggestion.
Yes, I think it's always very interesting, isn't it? I think also the extreme ends I find always very interesting, the controls who are just on the border of being progressive, and the Alzheimer patients who are at zero, when you think, what's going on there? Do you have any ideas what's happening there, or for those specific cases?
Yeah, well, I think there's this concept of cognitive reserve, which is very interesting. So there is some evidence that if you're well educated, if you're more social, if you have a sort of higher standing career, or your brain is a bit protected from these diseases. So you might have the pathology in your brain of Alzheimer's disease, but actually you can compensate for a period of time. What's interesting is then when you do get the disease, you don't die at a later stage. So actually your disease is more rapid when it comes on, but it just comes on a bit later because you're able to compensate for a bit longer.
So you think that might contribute to the progression, or at least at the beginning.
Yeah. And we've looked at this with brain imaging and brain activity. And your brain activity is organized into different networks, and you can efficiently organize your brain activity to compensate for those diseases for a period of time. And then when you get the symptoms, that sort of compensation in those brain networks falls apart. So it's something to do with that cognitive reserve, education, and social activity, and reorganizing your brain networks to compensate.
Great. And Louis has another question. It looks like the science of predictive diagnosis is progressing faster than the science on treatments, which perhaps poses potential ethical issues of informing middle-aged patients without clear hope for improvement yet. How do you think we can best address this discrepancy?
Yeah, it's a really good question. I almost put a slide about this in the presentation. I probably should have done. So I think it's a key thing, and I think it's interesting that the language around this is changing slightly. So if you look a few years ago, people talked about pre-symptomatic diagnosis of Alzheimer's disease, and actually now the language is moving to identifying people who are at high risk of developing Alzheimer's disease. So I think this is more about risk than diagnosis, because even a lot of these biomarkers which we're developing, they're not 100%. So you can have people often talk about an amyloid PET scan, so looking for these amyloid proteins on a brain scan, and you can do that to pick up Alzheimer's disease. But if you look at people who are aged 80, who are cognitively normal, have no memory and thinking problems, about 2/3 of them will have a positive amyloid PET scan. That doesn't mean they've got Alzheimer's disease. It doesn't mean their memory is going to deteriorate, but it means they're at high risk of that in the future. So I think we have to couch this in terms talking about risk, and talking about it in a positive way, and things that can be done to address that risk. In the same way that we might do about stroke with blood pressure management, or pre-diabetes and obesity and diet and things like that. I
think that's a really important point, isn't it? That it's not all or nothing. People, and that's what the data shows, that even with existing medication or existing lifestyle changes, you can actually change your risk still quite a lot, actually. So it's if you know early enough, I guess. Yeah,
and it's really interesting. If you look at the population as a whole, the rate of people per head of population with dementia is actually going down. There are more people with dementia because there's more people, but actually per head of population it's going down because people are have healthier lifestyles, their housing is better, they're controlling their blood pressure and so on better. So it shows that you can reduce your risk, but you might have to start very, very early.
Yeah. So Nada has another question. She says, related to cognitive reserve and populations with low levels of formal education, would you expect that progression would be apparently faster to all diagnostic groups in this case?
So actually it's the other way around. So if you have low levels of education, you'll get your disease earlier, but it will last longer. So you tend to progress more slowly. And that's been found in a couple of studies now. that's the case. I was actually at a meeting on cognitive reserve last week where someone was presenting another study which showed the same thing, that the better your cognitive reserve, the later you get the disease, but the faster it progresses. I think there's an open question in terms of all diagnostic groups. Does that cognitive reserve apply, because most of these studies are in Alzheimer's disease, does it apply to rarer dementias like frontotemporal dementia and things like that? And there is starting to emerge a bit of evidence that that cognitive reserve hypothesis does apply to some of these other types of dementia as well, but that's still early days.
But does then survival change, or is it really just the onset and the progression between those groups?
It's just the onset that changes. So your time, you will still die of these diseases at the same point, but it's whether your onset is here or whether your onset is here. So it's that sort of, and of course, if your onset is closer to death, then your decline is going to be faster if it's further away.
So ironically, this means then people with low education might be able to detect earlier and intervene maybe earlier. It's interesting, isn't it?
Yeah.
Theoretically.
Yeah. No, I think that's true. Yeah.
Russell has a question. At the site, you mentioned using the new diagnostic tool in regards to the support in the future to slow down dementia. Are patients encouraged to seek support? At the Alzheimer's Society, we get several referrals from memory clinics, but when we contact patients, very, very few, if any, take up future support.
Oh, that's very interesting to hear. Yeah. I mean, I can certainly talk for the memory clinic at Addenbrooke's, where we do encourage people to seek support. I think that the post-diagnostic support of being able to follow up people, we don't do as well in the UK as I think we could do, and I think it's very hard. If you've got dementia, then often your main carer will be someone of a similar age. So it might be someone in their 70s or 80s who's then taking on all that responsibility. It's that time of life when you're either slowing down or becoming the king, one or two of the other. So it's quite difficult then to suddenly coordinate all these different people that you can potentially get support from. So I wonder whether some of that that sort of comes into play, that people don't seek the support they should do because it's just overwhelming. But I think not everybody wants the support either. So if there's, for example, offering support groups, that's not for everybody. Some people find those groups incredibly useful to talk to people who are in the same situation. Some people don't like it because they'll see other people who are more advanced than they are, or they just don't want that social interaction. So I think we need to be better at being proactive in following people up after diagnosis, and offering people a range of support which is appropriate for them.
Yeah, clearly. Ramaswamy is asking, does someone with higher cognitive reserve show changes on the scan also later?
No, they don't actually. They'll. I mean, this is. I say that with some confidence, but it's not. There's very few studies which have really looked at looked at it well, but the underlying sort of neuropathology, if you like, and the changes on the brain scan are no different if you have that sort of high cognitive reserve. So there isn't any evidence yet that high cognitive reserve affects the build-up of proteins or that sort of pathology as such. Yeah.
Great. Any other question? Please feel free to type them in the chat or come on video if you want to. I have another one, I think, because I know this is a bigger challenge, but of course, many people who get a diagnosis of dementia never get an MRI scan, they get a CT scan maybe. Yeah. Have you looked at that as a potential route as well to do your algorithm on?
We haven't yet, mainly because you can do more with MRI scans. So
of course,
it tends to be a better scan. I have had a chat with some colleagues in London who are taking an interesting approach to this, and using an artificial intelligence algorithm to convert a CT scan into an MRI scan. So you get a sort of a CT, turn it into a structural MRI scan, and then you can use that to put into your algorithm. So it's not something we've done yet, but I think it's the quality. a few years ago, you might have said, well, CT scans are on the way out because they're just, they're not as good as MRI scans. The quality is not as clear. But actually, modern CT scanners are very good, and you can see almost as much detail as you can on an MRI scan.
Yeah.
So I think it's definitely something we should explore. In our particular study, we're just collecting MRI and focusing on that. But
no, it's not a criticism. It's just really a question whether you're going to look into this, because we see many people here who get maybe a CT scan but not an MRI, or at least the diagnosis is unclear. Yeah,
it's one of the big challenges that across the country there's massive variability in what people get when they go to a memory clinic. What diagnosis you get varies hugely between different clinics. Your chance of getting a diagnosis at all, your chance of being referred for post-diagnostic support, your chance of getting a brain scan in the first place, and your chance of that brain scan being a CT or an MRI, they all vary massively between different clinics across the country. So I think that's something that we do need to address.
Great. Well, if there are no further questions, Dan, would you mind putting in our email address? Hang on, there's just one came through again from Ramaswamy. What is the explanation for why scans do not match ACE3 scores?
Yeah, so the ACE3 is a sort of cognitive test, a sort of memory and thinking test. So there's lots of things which will influence your performance on a cognitive test. Being in Cambridge here, we see people from, we see professors from the university who come along to get their cognitive testing done, and the ACE3 is scored out of 100. We do the ACE-R, but it's very similar. So if someone, if a professor gets 90 out of 100, that's probably below what they should be getting. We also see people from the FENS who've never learned to read or write. So if they're getting 85 out of 100, they're probably doing better than we'd expect them to, because there's a lot of reading and writing to do in the test. So your sort of background education influences your test score a lot. And also this, I think this cognitive reserve has an influence. The type of dementia as well, and the particular symptoms that people have influences how you do on the test. So there's a whole section, for example, in the ACE3 on visuospatial function, so how the brain puts together things that you see. If you have posterior cortical atrophy version of Alzheimer's disease, you'll do very poorly on that particular bit of the test, but you might do better on the memory bit. So in that way, the amount of damage you have on your brain scan, if you like, will not necessarily match how you do on the cognitive tests.
I think Ramaswamy just followed up with, it meant even if appropriately done, in some cases to have the same ACE3 scan findings can differ. I guess even if you have the same background, I guess, and then the same scores, can then the scans differ?
Yeah, absolutely, and you can get a score on the ACE3, but by different routes. You can get marked down in different ways on that test. So yeah, the scans don't match up with the clinical presentation very well, and that's something that we're trying to understand in some other bits of my research, is to try and work out why people with similar looking brain scans actually have different symptoms, or the same disease, but they have different symptoms. What influences that? And there are some genetic factors that influence that. We're sort of looking into that. It sometimes depends on which specific bit of the brain is affected, but also people's background and sort of pre-morbid sort of function as well might affect it.
Great. And so I think if you have a question which maybe wasn't addressed, or you wanted to ask Tim directly, you could write to our email address, which is dementia.research@uea.ac.uk. It's in the chat. Also get in touch if you want to be put on the email list, and we will have the talk as well edited on the on our website if you want to watch it again in the future, very likely only after Christmas now. But just to say again, thank you for Tim for giving us a fantastic presentation and coming along and spending time with us. I think it was very helpful, and we can see already in the chat people are very happy with it as well. And we have the schedule for 2023 is not yet completely fixed, so we'll be in touch via the web, the email list, and let you know who will be speaking in 2023. Thank you, and my goodness, I'm saying for the first time, have a lovely Christmas to everyone. That's strange, but there we go.
almost too early. Thanks
Bizarre.
again, Michael.
Great. Thank you so much, Tim. Yeah.
Yeah, and thanks everyone for the questions and discussion.
Bye.
Bye.